All right, let's jump right in. We're going to tackle a question that's on the mind of pretty much every gastroenterologist. After a colorectal ESD, what's the right move for restarting a patient's DOAC? Well, a huge new study out of Japan just dropped some really compelling evidence that might just change how we all practice.
So here's the core of the problem, right? It's a classic clinical dilemma. If you restart that DOAC too soon, you're staring down the barrel of a major post-procedural bleed. But if you wait too long, you're leaving your patient vulnerable to a catastrophic clot, like a stroke. It's a real tightrope walk, and we all feel that pressure.
So here's how we're going to break this all down. First, we'll talk about that delicate balancing act. Then, we'll look at why the global guidelines are so confusingly different. After that, we dive into the landmark Japanese study itself, check out the decisive results, and finally, think about what this means for our day-to-day clinical practice. We're all seeing more and more patients on DOACs, and managing them around a high-risk procedure like a colorectal ESD is, well, it's a major challenge. We know ESDs already have a higher risk for delayed bleeding, and throwing a DOAC into the mix can double that risk. But the other side of that coin is just as scary. Stop the anticoagulant for too long, and you risk an irreversible event like a massive stroke. So you look to the guidelines for help, right? Well, that's where the problem starts. There's been a real lack of big comparative studies, and that's created a huge evidence gap. And what happens then? You get inconsistent, even contradictory advice from major international groups, which, leaves us clinicians kind of stuck in the middle. And wow, does this slide lay out the problem perfectly. On one side, you've got the Japanese guidelines from 2017 saying, go ahead, restart on day one. But then you look at the European and UK guidelines from 2021, and they're saying, whoa, hold on, wait 2 or 3 days. So who's right?
So to finally get some answers, researchers in Japan did something brilliant. They tapped into a massive nationwide inpatient database to run a huge retrospective study. The whole point was to directly compare these two approaches and figure out, once and for all, what the optimal timing really is.
And when I say huge, I'm not kidding. They analyzed data from more than 176,000 colorectal ESD procedures. That kind of scale is exactly what you need to get real statistical power, especially when you're looking for relatively rare events like thromboembolism. Okay, so this chart shows how they zeroed in on the right patients. From that giant pool of 176,000, they identified 3,550 patients who restarted their DAC within 3 days. And here's the key part. They split them into 2 groups, the early group, restarting on day 1, and the delayed group, restarting on day 2 or 3. That's the head-to-head comparison we've been waiting for. So, what did they actually find? This is where it gets really interesting. They used some pretty sophisticated stats to make sure it was a fair fight, comparing rates of delayed bleeding and thromboembolic events over 30 days. And honestly, the results were crystal clear. All right, let's break down this forest plot because this is really the money shot. Look at the top line for delayed bleeding. See how that horizontal line crosses the vertical no-effect line? The odds ratio is 1.05. Bottom line, there was no statistically significant difference in bleeding risk. Now look at the bottom line for thromboembolic events. The entire line is way over to the left. That odds ratio of 0.45 means early resumption cut the risk of a clot by more than half. It's a huge protective effect. So let's just spell this out. Finding number 1. Restarting DOACs the day after the procedure did not cause more bleeding. The big fear that an earlier restart would be riskier, well, in this massive data set, it just didn't happen. And then there's the other side of the coin, the real game changer. Starting DOACs early was linked to a 55% drop in the odds of a thromboembolic event. That's not just statistically significant, it's incredibly clinically relevant. It directly challenges the whole reason for waiting longer. So, what does all this mean for us back in the clinic? Well, these findings are pretty profound. They strongly suggest that the more cautious approach we see in some of the Western guidelines might need a serious second look. The researchers themselves put it perfectly in their conclusion. They state it plainly, and I'm quoting here, "Unnecessarily prolonging the resumption of DOACs may not be advisable. It's direct, it's clear, and it really captures the core finding of their work." So let's boil this all down. What does this mean for your practice? Well, we now have powerful evidence supporting a day 1 restart. This directly challenges those more cautious European and UK guidelines. And maybe most importantly, it reframes that risk-benefit talk we have. A delayed bleed, while serious, can often be managed. A major stroke, that can be irreversible. This data gives us a much stronger foundation for shared decision-making with our patients. And, they dug a little deeper and found something else that's really useful. When they looked at the different DOACs, it turns out Dabigatran had the highest risk of delayed bleeding after an ESD. Apixaban, rivaroxaban, and edoxaban all seem to have a lower risk. It's a great clinical pearl that suggests the specific drug we choose really can matter.
So we'll leave you with this thought. We're looking at powerful evidence from nearly 200,000 procedures that says restarting DOACs early cuts clot risk without increasing bleeding risk. So the question is your current protocol aligned with that data? Something to think about. Thanks for watching.